Thanks very much, Atul. Thanks very much for inviting me. I hope everyone can hear me. Can you hear me, Atul? Is it okay?
Yeah.
Perfect. Okay, great. So we're going to talk through where I think preschool wheeze is heading and have a little bit of a focus on the role of infections in this condition. I know that there were some talks on preschool wheeze yesterday. I'm hoping there won't be too much overlap, and I'm hoping I'm going to cover some different areas. Why do we need to talk about the future of preschool wheeze? Well, the bottom line is because we're not improving our management of these patients. So if we look at the size of the problem and how it's changed, in the UK, this is data from the British Thoracic Society audit that was done annually between 1998 and 2005, looking at admissions for wheeze or asthma in children of all ages. And if you look at this data and you look at the numbers in the red box, it highlights the number of admissions that we had. Oh God, I can't remember how I do the pointer. Anyway, the red box highlights the number of admissions that we had in children aged between 1 and 5 from 98 to 2005. And what you'll see is very consistently, year on year, the number of admissions is 75%. So 75% of all admissions for acute wheezing and asthma are children aged between 1 and 5. Now, that was between 1998 and 2005. So surely in the last 15 years, we must have improved. Well, actually, if we look at the size of the problem in 2015, when this audit was done again, exactly the same percentage of admissions for children between 1 and 5 for acute attacks of wheezing. So why do we need to think about the future of preschool wheezing? Because our management and our prevention of acute attacks or admissions for acute attacks has just not changed. We're not doing very well at all in the management of these children. So what are we going to do? Well, let's think about how we classify these patients and why is it important to even think about improving things? Why don't we just let them be 75% of all of the admissions and so what? Well, other than the significant healthcare burden and the impact on healthcare resources, there's something really, really important in the context of preschool wheezing. Now, we all know that clinical preschool wheezing can be defined according to wheeze phenotypes. And we have persistent wheezers who we think will go on to develop asthma. But then we also have this group who are the transient wheezers. They wheeze predominantly in the first 3 years of life and then grow out of their symptoms. And we call them transient wheezers or viral wheezers. And until recently, we used to think that the persistent wheezers were bad news because they went on to get asthma and they were a long-term problem. And I think we used to think that the viral wheezers were perhaps less of an issue because they grow out of their symptoms. So why do we need to worry about them? Well, what I'd like to say is actually, I don't think viral wheezing is benign. And we need to stop that mindset that, oh, you're just a viral wheezer, don't worry about it, you're going to grow out of your symptoms, because the long-term consequences are quite significant. So if we look at lung function in persistent wheezers, so they're shown on this graph as the open circles. Persistent wheezers are born with relatively normal lung function. It reduces significantly until the age of 6, but even into adolescence, they have significantly abnormal lung function. And we've known that, and we've been aware of that. But what I think we need to remember is that the transient wheezers, the black squares here, although they have some catch up in their lung function over time, actually by 6 and adolescence, they're looking exactly the same as persistent wheezers. So we get very worked up about the persistent wheezers who go on to get asthma, but we get far less worked up about the transient wheezers. But if we look at lung function, they're looking exactly the same in adolescence. It doesn't matter what their phenotype was in the preschool years, if you wheeze in early life, how you look in terms of lung function in adolescence is not good news. You have a significant reduction. And this is some really recent data from all 5 UK birth cohorts combined, which shows that it doesn't matter what your phenotype was when you were a preschool wheezer, whether you were a preschool remitting wheezer or a late onset wheezer. If you had preschool wheeze that was frequent, So compared to never or infrequent wheeze, your lung function in adolescence is significantly reduced, regardless of the phenotype. So we've got to beware, and we've got to stop thinking that viral wheezing or transient wheezing is benign. And this is, again, data from the Tucson cohort, which I started off with, the clinical phenotypes. And what they did was lump all the wheezers together and just look at lung function trajectory, regardless of phenotype. And if you do that, you find two trajectories. The one on the left, which is a normal lung function trajectory, where by early adulthood, if you look at the age of about 20, the children are reaching a good peak of FEV1 of about 80%, FEV1 being shown on the y-axis. But there's a low trajectory group who never reach maximum normal FEV1. Into early adulthood, their sort of maximum FEV1 is suboptimal. And the factors that are associated with a low lung function trajectory are maternal asthma, early RSV illness, active asthma at the age of 32, but this is key. If you had low lung function by the age of 6 years, you're set on a low lung function trajectory. So preschool wheezing associated with low lung function is not good, and the long-term outcomes are bad. And this emphasizes that even more because this is data from adult cohorts, 3 independent adult cohorts, divided at the age of 40 according to whether they had low FEV1 or a normal FEV1, followed up for 22 years up to the age of 60 to see who developed COPD. And what's really interesting is if you had a normal FEV1 greater than or equal to 80% at the age of 40, and if your rate of decline in lung function beyond that was 24 mils per year, so a normal rate of decline in lung function, you do not have COPD by the time you're 60. But if you have a low lung function at the age of 40 with exactly the same rate of decline, you now have COPD by the age of 60. So I think what happens is we're all completely set almost by the age of 6. If we've wheezed in early life and we've got low lung function in early life, you're set on this low lung function trajectory. So we have to think about improving our management of preschool wheezing because there's 2 factors that determine that low lung function. The first is severity of your attacks, and the second is frequency of your attacks. So this is some data that hopefully will convince you that severity is important. So these were children who were admitted, so they were bad enough to be admitted in the preschool years with a viral wheezing episode, and they were followed up at the age of 17 to 20 with assessments of lung function and exhaled nitric oxide. And you can see the ones that were admitted, at least half of them were on inhaled steroids in early adolescence or early adulthood, and half of them had been given a diagnosis of asthma. And it's not just RSV that's the problem. I know there was a talk yesterday on RSV, bronchiolitis, and subsequent asthma, but what we're learning more and more is rhinovirus-induced wheezing in early life is just as important in determining long-term poor outcomes. And in fact, any viral-induced illness is probably important. So the kids that got rhinovirus-induced wheezing had a high exhaled nitric oxide in adolescence and young adulthood. And it didn't matter what the cause of your wheezing was. In young adolescence and adulthood, you had small airways dysfunction. So severity of wheezing and frequency of wheezing in early life is really important in determining what happens in long term. So why am I saying all of this? I'm saying all of this because I've just shown you that we've not reduced the number of attacks these children are presented with. Year on year on year, 75% of all admissions are preschool wheezers, and this is not benign. We need to improve the way in which we prevent attacks so that we can reduce this impact on lifelong lung function. So how are we going to optimally prevent preschool wheeze attacks? Well, we need to know a little bit about the pathophysiology if we're going to know how to target treatment. And what we know is that if you look in the blood or the airways of severe wheezers, preschool wheezers, but when they're stable, the one thing that does not differentiate wheezers from controls is the number of eosinophils in their airways or the number of neutrophils in their airways. Yes, the blood eosinophils are a bit higher, but I think that's predominantly just driven by atopy. I don't think that's driven by wheeze, and it's really important to remember that. So just looking at wheeze versus control to decide what treatment to give is not helpful. So what are we taught to do at the moment? Well, what we're taught is that if you have viral wheezing and you only wheeze in discrete episodes, in terms of maintenance treatment, these kids should not get anything. They shouldn't get low-dose inhaled steroids. They shouldn't get anything regularly. But if you're a multiple trigger wheezer with acute wheeze episodes and symptoms in between, you should get maintenance inhaled steroids. That's what the European Respiratory Society currently tells us. What does that assume? Well, that assumes that the episodic wheezers have no airway eosinophilia, and the multiple trigger wheezers do have airway eosinophilia. Because the reason we use inhaled steroids for the treatment of wheezing or airways disease or asthma is to target eosinophilic airway inflammation, eosinophils in the airways. So, do episodic wheezers have any eosinophils in their airways? And do multiple trigger wheezers have any eosinophils in their airways? Well, here's the data. The bottom line is that you cannot distinguish episodic wheezers from multiple trigger wheezers by looking at eosinophils or neutrophils. They're identical. They completely overlap each other. Some multiple trigger wheezers have airway eosinophilia, some episodic wheezers have airway eosinophilia, and some have neither. So using these clinical phenotypes is not going to work if we decide how to use maintenance treatment to prevent attacks in these children. Another reason it's not going to work is because these clinical phenotypes are not stable over time. So this graph shows the wheeze phenotypes on the y-axis, and then that they were followed up over 2 years. And what you can see is if you're a multiple trigger wheezer, then at baseline, you'll be a multiple trigger wheezer. At a year, 80% are no longer a multiple trigger wheezer. And at 2 years, again, 80% are no longer a multiple trigger wheezer. These clinical phenotypes are not stable over time. You can switch phenotypes over time. And this is some more recent, really nice data that really shows that we cannot rely just on clinical phenotypes to decide how to manage preschool wheeze. So this was data in which parents of children with wheezing were given a diary to keep their symptoms recorded weekly for 12 months. And then every 3 months, they were seen in the clinic. And the diary-based classification was compared to what the clinician thought from the history. And this is the data. So what you can see is each 2 columns is a time point. They were seen at 4 times, 3 monthly over a year. The left-hand column is what the diary classified them as, and the right-hand column is what the clinician classified them as. And you do not need statistics. You do not need to be a science whiz kid to see that none of these columns have any agreement between each other. What the diary said about episodic wheeze is very different to what the clinician thought about episodic wheeze and how they classified it. So we cannot use parental reports and rely on subjective reports from parents and our interpretation of their reports to classify wheezing and decide who should get maintenance treatment or not. We have to use something else. We need objective markers to decide which children should get which treatment so that we can properly prevent attacks. Now, what I've told you already is we cannot use clinical phenotypes to decide who's got bowel eosinophilia or airway eosinophilia. But what we can do is use atopy to decide that. If you put all wheezers together and just divide them according to those who are atopic and those that aren't, the ones that are atopic are much more likely to have lower airway eosinophils. It's not perfect and there's overlap, and I fully accept that. But it's much better than just using clinical phenotype. So now we've got a test. We've got a test. We can look for atopy. We can look for air allergen sensitization to help decide which children might respond best to inhaled steroids, which children might have lower airway eosinophils. And the other thing we can do is if we plot lower airway eosinophils directly with blood eosinophils. So if you take a blood and bowel on the same day and look at how they correlate, there's quite a reasonably good correlation between high bowel eosinophils and high blood eosinophils. So if you've got high lower airway eosinophils and your blood eosinophils are above 3%, you're very likely to find the patients with the lower airway eosinophils. So now we've got 2 tests that we could use to try and find the preschool wheezers most likely to respond to inhaled steroids. We've got blood eosinophils when they're stable, and we've got a test of aeroallergen sensitization. And this data really summarizes that. This was done to look for preschool wheezers who would respond differentially, have the best response to inhaled steroids. And the red lines here are the children that received inhaled steroids. And the yellow line is the ones that got leukotriene receptor antagonists. I just want you to focus on the red line. And I want you to focus on the ones that responded best to inhaled steroids in reducing the number of attacks that they had. What were the two things that decided which children would respond best to inhaled steroids? The first was aeroallergen sensitization, and the second was a high blood eosinophil count of above 300 cells per microliter when they were stable. So two tests to help us see which children are going to respond to inhaled steroids. Is that the answer? Are we all sorted? Well, we're not, because only a quarter of all preschool wheezers are atopic. So what do we do with the 3/4 who are not? So the infant algorithm, which is the algorithm I've just shown you on the previous slide, which says use aeroallergen sensitization and or blood eosinophils to help you decide who should get inhaled steroids, will only apply to a quarter of all of our preschool wheezers. What do we do with the 3/4 who are non-atopic? And I think this is why we haven't improved our admission rate over the last 15 or 20 years, because we haven't done anything about preventing attacks in this group, which is actually the majority of our preschool wheezers. So if we look in the lower airways of children of any age who are bad enough to need a bronchoscopy, and we look at the inflammation and we do an unbiased cluster analysis, this is what we get. The green circles here are school-age children, and I'm not talking about those, so I'm just going to not think about those at all. But the red circles are a cluster of preschool wheezers who have aeroallergen sensitization and respond to inhaled steroids. They're the group we've just spoken about. But look here, there's another preschool wheeze cluster who are now neutrophilic. They have lower airway neutrophilia, and they are refractory to steroids. So this cluster is the cluster that until now we've known nothing about, we've done nothing about, and we've actually, I think, ignored. So how do we identify this cluster? What treatment should we give this cluster to try and improve our management of preschool wheezing? Well, one thing we need to think about is that there is definitely a group of preschool wheezers who, even when they are stable, have evidence of bacterial infection in their lower airways. So about 50% of wheezers, when they have a bronchoscopy, when they're well, have bacterial infection in their airways, which is associated with neutrophilia. So maybe this is the way of identifying that neutrophilic blue cluster. Maybe it's the bacterial infection that allows us to identify them. That data was from Germany. This is our data, as you can see, from 15 years ago. But even then, when we were bronchoscoping preschool wheezers, we found about 50% had evidence of bacterial infection in their airways, a really consistent finding throughout the studies that have been published. Hello? Okay. Now, the clinical wheeze phenotype does not allow us to distinguish who's got positive bacterial culture or not. But we've also found in our data that if you just take all wheezers with bacterial infection, with having a bronchoscopy, and split them into those with a positive bacterial infection versus a negative bacterial infection, the ones with positive bacterial culture definitely have increased neutrophilia. It's not ideal. There's a lot of overlap, but there's a definite indication that infection, bacterial infection, is associated with lower airway neutrophilia. And when you look by the microbiome, so until now, the data I've shown you was traditional culture. But if we look at these children using the microbiome, we find two clusters, a Moraxella predominant cluster and a mixed microbial cluster. The Moraxella predominant cluster are the ones that have the neutrophilia. And the abundance of Moraxella, the right-hand graph here, if you look at the abundance of Moraxella, then there's more neutrophils in the airways, suggesting that it's the infection that's driving the neutrophilia. The more Moraxella you have, the more neutrophils you have. So the thing perhaps we should be targeting in this cluster of patients is the infection. I don't think we should be targeting the neutrophils. The neutrophils are probably there because of the infection, but if we target the infection, maybe we'll get on top of preventing attacks of wheeze. So does that work? Well, there's no randomized control trial. There's no prospective data that has looked at this. This is the only data that's come in with an intervention in these children who have bacterial culture positive in their lower airways. And as you can see, if they were given prolonged course of antibiotic therapy between 2 and 16 weeks, then 12 months later, so 12 months after the course of antibiotics finished, the number that had episodes of breathlessness halved, the frequency of the episodes reduced, and the admissions reduced. So there's this definite group of preschoolers, I think, whose disease is being driven by infection, who until now we haven't really thought about. But so then why isn't this just recurrent infections? What's so special about wheezing? Before I talk about that, I'll just tell you, you don't need to do a bronchoalveolar lavage in all of these children. There is a non-invasive test that you can use, and you can do sputum induction quite safely in preschool children. You use 3% hypertonic saline, chest physiotherapy, oropharyngeal suction, and we did this, as you can see, in a group of our patients. We got a sample in the majority with no significant adverse effects and a reasonable correlation of sputum with lower airway infection. It's not good to look for inflammation, but it's a good technique to look for infection. And it's definitely a non-invasive way of looking for infection in the child's lower airways when they're stable. So as I was saying, why is infection important in wheeze? Why am I even talking about it? Maybe it's just recurrent infections. Is there anything special about wheeze? Well, there is, because there's two big features of wheezing and asthma. The pathology is characterized by an abnormal exposure, such as infection, onto a susceptible airway wall, with the parallel development of both inflammation and remodeling to give you significant structural airway changes. You get a remodeled airway wall. This is key to the development of wheezing and asthma, these structural changes. These are what relate to the lung function changes and the long-term outcomes. So remodeling is key to distinguish wheezing from any other recurrent infection. So do preschool wheezers have remodeling? Well, at the age of 1, they don't seem to have much remodeling. But by the age of 3, they have definitely developed remodeling. And this is just one example of remodeling, which is the thickness of the reticular basement membrane. And that remodeling increases with age from preschool years up to childhood. So why am I talking about this? Well, I'm talking about this because I want you to understand that these wheezers, which are the red circles here, are different to other children with recurrent infections and bacterial infection in their lower airway, which are the blue triangles. So C positive means a control non-wheezer who has bacterial infection in their airway, whereas the wheezer, the red circle, has infection but is definitely a wheezer. And if you look at remodeling, the one thing that definitely distinguishes the wheezer from another child who's a non-wheezer is the remodeling. So remodeling is central to the concept of wheezing as well as inflammation. And if we want to improve things in the future, we've got to tackle both the inflammation and the remodeling. That does not change. So what have I said? Well, I hope what you've understood I've said is that I think there are two main things that result in wheezing in preschool children. The first, in a group of children whose wheezing is probably driven predominantly by allergies. And the other thing that's really important in another group of children, I think, is bacterial infection. The children that have mainly allergies have lower airway eosinophils, and the children that have infection have lower airway neutrophils. So there's a predominance of one or the other, depending on what caused that initial insult. But both of them have remodeling, and that's what makes wheeze, inflammation with remodeling. So, and then ultimately, the inflammation and remodeling result in the future low lung function and asthma and COPD. So what are we going to do about it? Well, for the ones who have got eosinophilic inflammation, we can use inhaled steroids. I've shown you how to identify those children, and they will reduce the number of attacks. But the moment you stop the treatment, they'll go back to baseline. The steroids will not prevent development of asthma if you stop the treatment. You need to keep the treatment going to reduce the attacks and improve symptoms. What can we do about this group? Well, it seems like targeted antibiotics is the way to go, but we have no evidence. There are no trials that have looked at the role of targeted antibiotics to prevent attacks of wheeze during stable disease. There's just no data. I think it's a big gap, and I think it needs to be done. But at the moment, we don't have the data to say it's going to work. I think it will reduce attacks if we find the right patients, and I don't know if it's going to be disease modifying. But if we want to stop asthma and COPD, there's no point just targeting inflammation. The key thing is to be able to target remodeling as well, so that we can impact the long-term outcome. And at the moment, we have no treatments that will target remodeling. So that's where I think we've got to go in the future with preschool wheezing. And that's it. I'm done.
Thank you very much, Sejal, for the excellent talk. James Chang, do we know that high pheno for the rhinovirus wheezer are a result of rhinovirus infection and not just because these patients have atopic tendency, hence more susceptible to rhinovirus-induced wheeze?
So I don't know the answer to that. We don't have any, what the difficulty is, we've got lots of epidemiological associative data. The thing we're lacking is mechanistic data that will tell us that if you give rhinovirus in early life, how that impacts what happens later on. So in that study, it was a cohort study, it was a follow-up study, just showing an association between children who had rhinovirus-associated wheezing in the first 2 years of life. If you check their pheno subsequently, it was higher. There's nothing else at all. It's all association. So I think that's the issue, is what we're lacking is that absolute causative data that links rhinovirus with subsequent allergy or asthma. I'm not sure it's going to be all atopy. I think there is definitely a link between the sort of pathophysiological features of asthma and early rhinovirus infection.
Thank you, Sejal. Couple of questions about neutrophilia. Does the airway neutrophilia correlate with blood neutrophilia in preschool wheezers?
No, and I think I showed that. Blood neutrophils are useless. They just don't correlate with anything. So, I mean, where's my slide? I'm sorry. No, blood neutrophils are not useful. It's the bottom line. They don't correlate with airway neutrophils at all. No.
Yeah, thank you. And again, on similar theme, could the refractory wheezer with neutrophilia in bronchoalveolar lavage be a silent aspirator?
So I think it's when you have severe wheezers, it's really important to look for other causes of the wheezing. I didn't go into that today, but one of the key things, and I assumed you'd had that maybe yesterday, is to look for differential diagnoses. Why are these children presenting again and again with wheezing? And one of the things to definitely think about is aspiration. I've only seen the link with neutrophils in association with infection. But of course, the important thing is what's causing that infection. And if a child is aspirating and getting recurrent infections, then that could be the reason that they've got the neutrophilia. I think the point I want to make is that there's a definite link between bacterial infection and neutrophilia. And it's really important to look for other causes of that infection and then treat those underlying causes as well as the infection. The group I'm talking about here are a group in which we've made sure there's nothing else really contributing to their wheezing, and they're kind of straightforward wheezers.
Thank you. Amanda Equi, again, practical question. If you're giving antibiotics, which one and for how long? And also, how long do you continue inhale corticosteroids for the atopic group? And given that parents are going to stop it anyway, will the child get better?
Okay, so if I take that first, hi Amanda. So the inhaled steroids has to be given as a trial. I'm not saying every atopic child is going to respond to them, and that's really, really important. So any treatment you start in these patients has to be given as a trial. And I would always give it as a trial for up to 3 months. So you start the inhaled steroids, you make sure the child's taking it properly, device, technique, bring them back at 3 months and ask them, has there been an improvement? Now, if there has been an improvement, it might just be the natural history of the disease and they were going to get better anyway, or they responded to the inhaled steroid. So actually, at that point, I would think about stopping. And then if the symptoms come back, then you put them back on it. But you're right. It's, a lot of parents will not give the inhaled steroids when the child is well, especially during the summer months. And I think you have to be pragmatic. And if they're only going to give it during the 6 months of the autumn and winter, then there's not much else you can do about that. But it has to be a trial, and you have to make sure they respond. Not every child will respond. In terms of the antibiotics, as I said, the only data we've got, Amanda, is that German data where they gave them from between 2 up to 16 weeks. Now, hey, pick a number. I don't know. What we do at the Brompton is we give them for 4 weeks. And then we see if there's been a response. And if necessary, sometimes you do need to give them for longer, up to 3 months. But I would say give them for 4 weeks in a treatment dose and see if they've responded. Oh, sorry. And which antibiotic? It should be a targeted antibiotic, not a blind antibiotic. Find the organism and treat. And the most common organisms are Haemophilus influenzae, Moraxella catarrhalis, and Strep pneumoniae. So usually we're giving coamoxiclav.
And again, Sejal, on the same thing, what about the impact of gut microbiome on frequent antibiotic or prolonged course of antibiotic?
Yeah, good point. There's 2 issues. There's the antibiotic resistance, and there's an impact on the gut microbiome. And I can't do anything about that. The ideal would be to give inhaled antibiotics. And I think that would be an amazing solution for these kids because, topical antibiotics, we use them in CF, we use them in our kids with bronchiectasis. Why can't we use them in these patients? Well, at the moment, we don't have appropriate inhaled antibiotics that will target those top 3 organisms. That's why we're not using them. I think that's something we really need to be thinking about for the future. But the gut, if it's a short term, yes, it's a long course, but if it's short term, hopefully the gut microbiome won't be significantly altered. And if we can make sure the parents are giving things like Yakult, etc., to try and keep the gut microbes as diverse as possible, then that would be good. But I don't know how else to do this at the moment. We don't have inhaled topical antibiotics.
Thank you, Sejal. And the last one from Tim Newson. Preschool wheeze is very common primary care problem. And so how do we deliver these assessments in the primary care? Or do we need a primary care pediatrician to follow these and manage these patients?
Completely agree, Tim. It's the most common thing that the GPs are seeing. I would argue that if we could make the GPs aware of the children that are... See, the thing I don't like is this concept of it's fine, he's a wheezer and he'll grow out of it. I think if we can make GPs aware that frequent episodes are not fine and require secondary care referral, and if we can make the GPs aware that admissions or severe episodes are not fine and require referral, then I think we'll get the patients that really need an intervention into secondary care and into the right place where we can do allergen testing, where we can do a full blood count. The other thing is that GPs can actually request a full blood count and specific IgE, because all of these tests need to be done when the child is well. None of them are needed when the child is unwell. So they can be requested electively. But I think the key is to get the message across that frequent wheezing is not benign. It doesn't matter even if it's viral wheezing. There's no such thing as a happy wheezer if he's wheezing month on month on month and week on week on week. And severe wheezing is not benign. So I guess it's a bit of education on both sides, primary care, secondary care, and us. Yeah. I hope that helps.
Thank you very much. There are still lots of questions, but I think I'll ask to contact you directly. I know you're on Twitter as well, so they can either follow you on Twitter or email you, or they can come live to see you next year in April.